Shannon and Dan here is they both have this strong history in looking at critically at prevention, at intervention from their history at the CDC, and for those strengths were brought over to the National SafeCare Training and Research Center to really focus on what can we do about neglect, how can SafeCare help. The other reason that I love that we have Shannon and Dan here is how many people in this room struggle with how do we best coach people to do any intervention that we're working on? How do we best train people? How do we use technology? How do we do things in a cheaper and better way? How many people think about that? I think about that a lot, a cheaper and more effective way. And so part of what they're doing, in addition to looking at SafeCare for neglect, is really looking at how do we do supervision better? How do we do coaching of interventionists, of home visitors better? What are the strategies? And they're using data to analyze that, while at the same time looking at how does SafeCare help prevent recurrence of neglect and address the problem of neglect. So I think they can say a lot and will be saying a lot for the field in terms of how we do those kind of things, which I think applies beyond even interventions for neglect, but a lot of the other interventions and things that we work on. The other thing I think you'll appreciate about their presentation is they're going to talk to us about SafeCare, and they're going to talk about what SafeCare can offer, but they also look at SafeCare critically as one of the things we're considering for neglect. Because there's programs out there, but like Lucy said, we're recognizing neglect as a problem, but we don't yet have a lot of interventions to target it, and SafeCare is one of them. So we're thrilled to have you guys join us. They presented at Grand Rounds for my division at UW on Monday, and everyone said it was one of the best Grand Rounds they've been to. So, not to put any pressure on you or anything for the FCAT talk.
Hi, everyone. We are so excited to be here today. We've been in Seattle since Monday, and we've been sort of doing presentations around the state, and we are both in love with Washington, and anytime anybody wants to invite us back, we are more than willing to come. It's just such a beautiful place, and it's been really interesting. We've learned a lot about the exciting work going on in the state while we were here, so it's great to hear that so many people are looking critically at how to best prevent and intervene with child maltreatment in the state, and we've really enjoyed the lovely scenery as well. So thank you for inviting us. Today's presentation, I'm going to start with going over the neglect basics. I think, all of us in this room are critically aware of the problem of neglect, but sometimes it's nice to just take a look back and look at kind of a summary of what the literature has to offer in terms of prevalence, risk factors, and outcomes for children who have experienced neglect. I'm also going to do some focusing on the differences between child neglect and other types of maltreatment, as well as the similarities, to kind of help us understand from an etiological standpoint where we should focus our interventions. Dan's going to take over then and talk about the available interventions for neglect, as well as interventions focusing on partner violence, because as we all are aware, in many of the families where children are experiencing neglect, there's also intimate partner violence in the home. Then we're going to move into a discussion of implementation issues, and this is really discussing implementation considerations for any evidence-based practice within child protection and child welfare. And at the end of each of these sections, we will take questions. So part one is neglect basics. And I wanted to start with just kind of getting us all thinking about neglect. It's a very difficult thing to define, and you can kind of understand this point if you consider some of these questions. So first of all, neglect is kind of an omission of behavior. And so to define this, in some ways you kind of have to understand what the minimum requirement for parenting is, which is critically hard to define. None of us really want to accept minimal parenting for children. We want children to be exposed to good parenting in homes. And defining neglect is really defining the absence of good parenting. And so it can be a really, really tough thing to put your finger on. You have to consider, what are the actions or inactions? Are they intentional? Do they have to be intentional to be considered neglect? So if a child is not being fed in a home, does it have to be an intentional circumstance on the part of the parent to be considered neglect? Probably not, because it can lead to difficult outcomes. What is the role of poverty? So when is it neglect when a parent can't feed a child because they don't have the resources to feed them, as compared to just not thinking of feeding their child in the situation? How does child development play a role? This is really a critical issue. So if we really wanted to kind of conceptualize all the behaviors at each developmental age that would constitute neglect, it'd be very different across the lifespan. For instance, at age 4, a child being left at home unsupervised for a couple of hours would be absolutely unacceptable and would be considered neglect by, I think, most people. However, at age 12, I think it would be a very different situation. What are the one-time behaviors that are considered neglect versus behaviors that must be chronic to constitute neglect? So if you think about physical abuse, a one-time hit that leaves a physical mark, that's physical abuse. However, in neglect, it can be either a one-time behavior or a chronic behavior. A one-time situation might be a child being left unattended in the bathtub and it resulting in injury. Well, that is a one-time situation that, you can constitute as neglect. However, something like poor nutrition might need to be more chronic for you to be able to define that as neglect. What is the role of culture and religion? These are very important factors to consider in whether or not neglect is substantiated. And for physical abuse, again, if you think about it, it's a little more black and white. So if you hit a child and leave a mark, no matter if it's culturally acceptable or acceptable by your religion, it's still physical abuse by our standards. However, this is much more complicated in terms of neglect, especially when it comes to medical neglect and how religion impacts parents' decisions for medical needs of children. So I say all this to just kind of confuse you and make you understand why it's been so hard to define neglect and conduct research on it, because it is very, very difficult to conceptualize exactly what it is. It's a complicated issue, and we all know that because we've worked with these families. I don't know how many of you had the chance to listen to NPR yesterday, but there was a great report on NPR documenting sort of the state of child maltreatment prevention and intervention. They focused a lot on the state of Oklahoma, but it is a story that's ringing true across the U.S. And even the reporter in this in this particular story came to the conclusion that this is really complicated because there's no federal definitions for child maltreatment, and what's maltreatment in one state is not in the other, and this is really confusing. Take the case of a toddler who gets outside his or her house and is hit by a car. When is that an accident? When is it neglect? How do you assess parental supervision in that situation to determine, whether it was one thing or another? So it's not a conclusion that our field has come to. It's also, anyone who sort of starts investigating neglect really comes to the conclusion that this is a complicated issue. Now, Dan and I did work at the CDC for some time, and the CDC has put out some uniform definitions to try to really help move our field forward in defining child maltreatment subtypes in the same way, so that it can really help focus research and clinicians and states on working together to have a uniform definition. The CDC uniform definitions constitute neglect really, again, as an act of omission by a caretaker or parent. And they have two subcategories, a failure to provide and a failure to supervise. Failure to provide includes physical neglect, which is poor nutrition, poor shelter, poor clothing, not meeting basic needs of a child. Emotional, which is really poor bonding with a child, lack of affection, no emotional support with a child. As an infant and child grows older, this can also constitute things like ignoring significant mental health problems that a child may be experiencing or drug abuse that they know is going on. Medical issues, which is really related to sort of the denial or lack of access to medical resources for a child. And this can be both in chronic medical health cases, not following through on treatment plans, lack of treatment compliance, or even, in early childhood, not following through on standard appointments for children. Educational neglect is something that occurs obviously more often in school-age children, because that's kind of part of the definition. And it is when a parent either doesn't enroll a child in school who is of school age, or is allowing truancy, or is not following through on getting special needs that a child is exhibiting met in the school system, so not following through on testing or permission to get child access to educational services that are required for school success. Failure to supervise, it comes back to more that supervision role that I mentioned earlier, so inadequate supervision by a parent that can really increase endangerment or harm for a child in the home or community setting, and exposure to violent environments. These are data from NCANS, which document the substantiated cases of maltreatment in 2007. Probably all very aware of these data, but I think the important take-home point again is that the blue section of this pie is those cases of substantiated neglect. The red piece of the pie that's next to it is multiple maltreatments, which often also constitute neglect. And so if you look at those two together, it's really taking up the majority of the piece of this pie chart. And so it really is clear that neglect is the #1 problem in the child protection system. We all understand that substantiated reports are a significant underestimate of child maltreatment, and this could even be more so in the case of neglect because there's research suggesting that caseworkers are less likely to substantiate neglect as compared to other types of maltreatment because it's so hard to define and it's often less verifiable than the more acute sensational type cases. In the NCANS data, they also do some analyses that look at differences in maltreatment types by age, by gender, by other demographic factors related to the child. And in this data, it is clear in terms of substantiated reports that children who are under the age of 7 are most likely to be substantiated for neglect. And there was some disproportion according to race in terms of medical neglect, with African American children being at greatest risk. Now, it's important to consider other types of data when you want to understand the full scope and magnitude of maltreatment. When looking at the National Incidence Study of Child Abuse and Neglect, which looks at the 2005-2006 year, this report considers information from both CPS data, so substantiated reports, as well as reports from other agencies that work with children, so education, medical workers, these sorts of agencies. Data was collected in 122 counties, and they classify maltreatment in terms of abuse and neglect, and they also have some categorization in terms of harm versus endangerment for children. Harm meaning the child was in fact harmed and had some physical or emotional consequence as the result of the maltreatment, whereas endangerment is a little more loose and a little more broad. It's that the child was at risk for being harmed, but it had not resulted in harm yet. The take-home point from these data is that they believe that a more accurate number of child maltreatment reports is about 1.25 million children a year. And importantly, if you look at the maltreatment types, and this is by harm standards, so these are children who actually had significant emotional, physical consequences, neglect is substantially more common than physical abuse or sexual abuse. In thinking about maltreatment trends, you can look at data from over the last 10 to 15 years, and it's pretty clear that while there have been substantial changes in physical abuse and sexual abuse, neglect has been continuously a problem. We haven't seen the declines in neglect that we've seen in other types of maltreatment. Now, one case of any type of maltreatment is too many, so I'm not trying to minimize the problems of physical abuse and neglect, but clearly what has been working in terms of leading to reductions in these types of maltreatment hasn't been working for neglect. There's a great article by Jones and Finkelhor that was published in 2006 that really tries to document some of the reasons that perhaps neglect has stayed more constant while physical abuse and sexual abuse have declined. They ask questions like, is neglect harder to prevent? And I think we all would say yes for that. Neglect is much more complicated. It's involved with social and ecological factors outside of the parent-child relationship. Are there social changes that are impacting child neglect and that are not impacting child neglect but are impacting child sexual abuse and child physical abuse, things like economic improvement, which is certainly not the case now, but when the data were looked at through 2005, that was something that occurred. There's also a much more intense response in terms of law enforcement over the last 10 to 15 years to child maltreatment cases. However, this is only really focused on child physical abuse and sexual abuse cases versus neglect. Has our field been neglecting neglect? And I think if you look over the last 20 years, there certainly has been some neglect of neglect, and these are kind of some of the the reasons why. Child protection systems are really set up to respond to recent, distinct, verifiable incidents. Programs, in terms of programming, the highest level of program prevention has focused on sexual abuse in the last 20 years, and there have been much fewer programs developed for child neglect. Law enforcement, again, I mentioned this earlier, they focus on cases where there's prosecution involved. Again, this is more relevant to physical abuse and sexual abuse and sometimes neglect, but not as often. Researchers also, researchers don't like to get their hands dirty a lot of times, and neglect is the hardest thing to study and make hypotheses about. And so for a lot of years, there was not a real emphasis on child neglect research in terms of federal grants, and people weren't publishing on it a lot. All the while, neglect has been the most prevalent and concerning problem in the child protection system. And so some folks have referred to child neglect as the poor cousin of child maltreatment research. Others have, my favorite journal title of all time is, why are we making a molehill out of a mountain? They're talking about the problem of neglect in this article. So I think these are important questions. We are really moving in a positive direction in terms of neglect. There have been positive clinical trends. We are really starting to pay a lot more attention to prevention efforts and evidence-based practices for child neglect. We certainly don't have all the answers or even a majority of the answers at this time, but we are definitely making progress, which is important. We have also seen some positive trends in research. CDC now has the definitions. We're starting to think more clearly about theoretical models that apply to neglect. The proportion of studies on physical abuse and neglect as compared to sexual abuse have increased, and the overall number of funded projects for all types of maltreatment have increased too. And I'll show you two graphs and charts that suggest this. So this just shows that the percentage of maltreatment publications on sexual abuse in the last 20 years has declined, whereas physical abuse has gone up more than neglect for sure, but at least they're being attended to in the literature a little more. Here's where the big difference is, and this is what we're excited to see, is that for all categories of maltreatment, federal funding has increased very much over the last 10 to 15 years. And it's certainly far more true for the physical abuse and neglect focus. So we're excited to see federal funding efforts focusing on these problems that are more prevalent for the everyday life of the child protection system. Now I'm going to talk a little bit about predictors of child neglect. And the resources that I pulled from are, here are the authors and the year published, and I can give you full references. I could certainly email that to Rima if anyone's interested. The DePampoulis 2006 report is actually available online. It was from the Office of Child Abuse and Neglect. And these other two articles are available in the literature. And so what I tried to do was just pull together summaries of different etiological factors based on a social ecological model. So what kind of factors are occurring at the community level, the family level, the parent level, what are parent factors that predict neglect, as well as the child level. None of these are going to be surprises to any of us. I think that we're all aware of the types of things that can increase the risk for neglect, but sometimes it's nice to just kind of see a summary of the literature all in one presentation. So hopefully this will be helpful in that way. At the community level, things like poverty as impoverished communities are about 18 times more likely to have significant problems with child neglect as compared to more affluent communities. Communities with high rates of school dropout. Now, the article that focused on this did not talk about the impact that teenage pregnancy might have on school dropout. And so I'm not sure, certainly adolescent age mothers are at greater risk for child neglect, and so there may be an interaction there that's a little less clear, but there was a correlation between school dropout and child neglect. Of course, more violent communities, communities with single-parent homes, communities with low social support. Some articles have found that urban areas are a greater risk. I'm going to contradict myself here shortly in another article that found rural areas to be at greater risk. So I think that research is not perfect, and I think we can say right now that we should be looking for neglect in both types of communities. Also, inaccessibility to health care. So this is really important for medical neglect. If there isn't available medical care to parents easily, then there's going to be greater risk for neglect in those communities. At the family level, we've broken down these data into home environment and family functioning. The home environment looks a lot like the community level data. So poverty and low income places a family at greater risk. More individuals in the home, and there seems to be some sort of magical change when a family reaches child number 4 that greatly increases the risk. I have one child, so I get it. I think most of us do. Certainly single and younger parents are at greater risk, and in 2-parent homes, the higher the parent conflict, the more risk there is for neglect. Now, important thing to consider here is that while each of these variables may increase the risk for neglect a small amount or even a large amount, the combination of any of these factors is really when the risk escalates greatly. So if you have, for instance, the research shows that if you have a single mom who's 17 or under, who's living in an impoverished area, that parent is going to have a much greater risk for neglect than a single parent in an impoverished area who's older than 22. So you can see how these factors can interact to really increase the risk. In terms of family functioning, all these factors really relate to the relationships in the home. So if the relationships in the home are really defined by high chaos, lots of stress, lack of expressive positive emotions, empathy and warmth and cohesion, you could understand that if this is how the family members are existing in their typical relationships, this is probably going to be how the relationship is between the caretaker and the child, and thus really increases the risk for neglect. Now, I mentioned earlier the National Incidence Study of Child Abuse and Neglect, and they've also in their data looked at ratios of increased neglect by community level and family level factors. And again, the news is not surprising. In communities where unemployment is high, there's 2.7 to 4 times the risk of neglect. Again, you see the importance of socioeconomic status for the family. Interestingly, though, everyone sort of focuses on poverty, you see that single parenthood had 12 times the risk, which was more than the risk associated with the low SES factors. Again, here's that magic number of 4 children in the home, increasing the risk. And here's where I'm going to confuse you and say that rural counties have 2 times the greater risk. So I thought it was important here to just kind of talk a little bit more about the role of poverty and neglect. And certainly it's been very hard to separate in terms of child outcomes. What's more primarily important. And so this study was really interesting. It was published by SLAC in 2004. And what this author did was really took a look in a large statistical model. I don't want to bore you here, so I'll try to do it pretty simply. Looked at a lot of variables that they thought would be associated with neglect, including demographic variables that I presented on, factors involved with the parent-child relationship. And they looked at 5 different types of poverty variables. 4 of those variables focused on things that an outsider could define poverty by. So just looking at the income of the family, looking at the material hardship of the family, looking at quarterly earnings of the family, as well as the amount of assistance, financial assistance that the family has received. One of the poverty variables, though, was rated by the parent themselves, and it was their perceived hardship as related to poverty. So when you put all these variables in a statistical analysis to understand what the role is in predicting neglect, 8 total significant variables emerged, but only one of the poverty variables emerged as significant in this model, and it was actually the parent's perception of the financial hardship. I thought that was really, really interesting and critically important. Other risk factors that were associated were the youngest child in the home, parent with a learning disability, cohabitating as compared to single parenthood in this study was found as leading to greater risk, and then 3 variables related to the parent-child interaction. One was parent-child interaction itself, which was kind of poorly defined because they defined it by the amount of time the child spent watching TV. So they took that as if the child is watching a lot of TV, that means the parent's not spending time interacting. So it's a little bit loose in terms of that factor, but it was significant in the final model. And then corporal punishment and parental warmth. Okay, moving on to parent-specific factors. These are the things we've kind of heard over and over already in this presentation and probably knew before you got here. Young parent age, more often female, and the literature suggests that that's because caretakers are more likely substantiated for neglect, and the caretakers just more often happen to be the female. These are the parenting characteristics that are associated with maltreatment, unemployment, underemployment, lower education, fewer parenting skills, which involves both knowledge as well as problem solving around good parenting, lower social support, and very, very important here, I think, is a history of maltreatment and intimate partner violence. So the literature suggests that if you look at mothers who neglect, they're about 3 times as likely to have a history of child sexual abuse as compared to mothers who don't neglect. Also, there is some intergenerational transmission of neglect, meaning that children who experience neglect in their childhood, about 20 to 35% of those children go on to neglect their children as adults. And as far as intimate partner violence goes, in about 35% of neglect cases, there is some type of intimate partner violence. And Dan will be talking more about the association between these factors in his talk. Again, parent mental health is something we really often hear about in terms of neglect. Lower self-esteem and higher impulsivity have both been found in the literature to increase risk for neglect. Depression and substance abuse, I put them on the same line because while they both independently do increase the risk for neglect, if you consider them together, it really seems that the substance abuse diagnosis is more important of the two. And in fact, Mark Chaffin found that substance abuse moderated the role between depression and neglect, meaning that if you put substance abuse into the equation, the importance of depression is decreased in terms of neglect. Higher levels of daily stress is another one. In terms of behavior of caregivers, let me talk to you about how this is usually measured in the literature. So it's either in a lab setting or in the home. There's someone kind of taking data on a family interacting with their child around tasks. And so we don't really know how valid these measures are, although there is some evidence that there certainly is validity to these types of measures. But if you look at neglectful mothers as compared to non-neglectful mothers, you see that there's more verbal aggression and lower verbal accessibility in neglectful mothers. And that simply means that there's not a lot of dialogue, and when there is, it's usually something like, stop doing that, move away from me. It's not really positive and engaging, nothing to really encourage more verbal interaction. In terms of behavior, there's lower levels of positive behavior like hugging and touching and patting on the back, and more negative behavior, sort of, subtly moving a child out of their space. I want to sit here on the couch, I want you to play on the floor. These sort of things are what distinguish the behavior of neglectful parents from non-neglectful. There are some child factors that place a child at greater risk. In no way am I indicating that you should blame a victim, but just be aware of different risk factors that can increase the risk of neglect. There's some mixed research on age, but the majority of research suggests that children less than 3 are at the greatest risk for neglect. Certainly we saw this in the CPS data that children under 7 were at the greatest risk. However, there are particular types of neglect that increase with age, and that's emotional and educational neglect. In terms of gender, there's not a lot of research on this particular factor, but at least in the National Incidence Study of Child Abuse and Neglect data, it was suggested that boys may be at greater risk for neglect. Behavior problems and disabilities also can increase the risk. The behavior problems is a tricky one because it's often relying on the parent's report of child behavior problems. And mothers and fathers who are at risk for neglect typically have a lower understanding of typical child development. So they may be rating child behavior problems when it doesn't exist. So this finding has to be thought about a little with some caution. There are also several studies indicating that children with disabilities are at greater risk for neglect. So that's a very important factor as well. This is probably not very readable. I did not follow the rules on this slide. It was supposed to all be 24 points, but this is from the pamphlet again, the article that I talked about earlier, the summary that I talked about earlier. And I think it just does a nice job of pulling together the different factors that were discussed today in terms of risk for child neglect and putting them into some sort of model that we can conceptualize them in. I mean, it's not really all that clear because every arrow is pointing to every other arrow, so basically, all these interact with one another and all these things place children at risk. But again, I think it's critically important to think about the interaction of these factors in placing children at risk. So one alone, the child may be okay. If you see multiple things in a family, those are the families you should really be paying a lot of attention to. So in terms of neglect and child physical abuse and child sexual abuse, the risk factors are similar for child physical abuse and neglect, but quite different from child sexual abuse. The perpetrators of child physical abuse are typically the primary caregivers. There are more often women than men in both types of maltreatment. Importantly, child physical abuse and neglect really tend to co-occur. There is research that indicates that child sexual abuse victims, while they are at greater risk for other types of maltreatment than non-maltreated children, they have far lower comorbidity in terms of maltreatment types as compared to children who are either neglected or physically abused. So these really co-occur more often than not. Child welfare service involving child physical abuse, I'm sorry, this statement is a little off. There's rarely child physical abuse cases that are seen in child protection that there isn't some type of neglect. This is what we see from reports. So again, just these families have multiple complications and again, documenting that these types of maltreatment co-occur. And finally, another thing that really differentiates neglect from child sexual abuse and child physical abuse in terms of the child protection system is that most often the response is to separate child physical abuse and child sexual abuse perpetrators from the child, whereas in neglect, that's not always the case. There's often a lot more strategies put in place to keep the family together and bring up the neglecting parent's skills to make them a better parent. This happens some also in child physical abuse depending on the severity. How can we distinguish neglect and child physical abuse? It's an important question, and I think, the etiological model focusing on child physical abuse suggests that it most often happens in the context of discipline. And if we think about the negative coercion cycle, for instance, you can understand that as a child's behavior escalates, that a parental response to that behavior escalates, and perhaps corporal punishment is reinforced because that decreases the problem behavior of the children. So all those factors are really related to the parent-child relationship. Whereas with neglect, it's just more rooted in broader social ecological factors. It's not just about the parent-child relationship. While that is important, it's also defined by all the other factors that I've discussed today. Another meta-analysis looked at comparing parent-child interactions among parents with and without a history of CPA and neglect, and results did show some distinct patterns for separating child neglect families from non-maltreating families and child physical abuse families from non-maltreating families. So there are some distinct behaviors that seem to be separating these groups. In terms of outcomes associated with neglect, again, just kind of going back to the earlier slides, before 1993, there were no reviews that summarized the impact of neglect on children. So in 1993, Crouch published a first review that was, just finally a nice document that you could read and understand the variety of impacts of neglect on children. And this study documented things like non-organic failure to thrive, poor intellectual development and school performance for neglected children, social isolation for these kids, and importantly, poor adult outcomes. So it's not just impacting them in childhood, it is a chronic and enduring outcome that you see for a lot of these kids. More recent research has continued this study, and not a lot of new things have been added in terms of outcomes. We just understand them a little better now. So we're understanding things like The children who are neglected have smaller brains than children who are not, and so that impaired brain development really sort of explains all these other academic and intellectual problems that we see with children. We're understanding more about the social and emotional withdrawal, as well as the continued prevalence of problems into adulthood. What's interesting is that a lot of these factors associated with neglect are not necessarily handled by the mental health system. So academic and intellectual difficulties, impaired brain development, that's not really something you can diagnose and bill Medicaid for. So, it's also not only in terms of considering preventing child neglect complicated, but often finding a creative way to work with these kids in the mental health system can be quite difficult as well. Outcomes specific to adolescents are interesting. There was one longitudinal study in which adolescents were asked about their experiences with neglect, and then it was examined where they were having problems during their teen years, and these are some of the associated outcomes: poor physical health, depression, substance use, violent behavior. I think another interesting point is that Dubowitz and colleagues really want to bring our attention to that, again, neglect is not one thing. Neglect clusters together many, many, many different types of parenting behaviors. And there may be a need for specific interventions based on the type of neglect that was experienced, because there does seem to be different consequences. Again, not very readable, but I could certainly, if you reference this article, you can be able to understand these different outcomes that are related to different neglectful behaviors. But an intervention that you might provide to a child who had inadequate food might be very different than a child exposed to family conflict, yet both of these can be considered within the neglect category. Outcomes as compared to child physical abuse. I think it's just important to know that while a lot of the outcomes are similar, there are some distinct outcomes that separate neglect from physical abuse. And these really come down to the cognitive and academic deficits, big issues with language, which impacts you throughout your life, social withdrawal, limited peer acceptance, and internalizing problems, which really often go unnoticed. They're harder to assess in younger children and throughout the lifespan, although we're getting better at it. Finally, one study referenced here at the bottom looked at neglected children, non-abused children, and physically abused children, and found that neglected children were more aggressive than non-abused children, but less aggressive than physical abused children. So there are some dichotomies and sort of some differences in that way between physically abused and sexually abused children. So before I hand it over to Dan to start part 2, I'd like to take any questions that you might have related to the presentation so far. Yes.
They looked at any differential effects of neglect, say, before 3 and neglect in early school age or anything?
So the question was differences in neglect at certain ages and child outcome. And I haven't seen any publications that have really looked at specific developmental age of neglect and how that relates to outcome, although it's a very great question. I think we'd be capable of doing that with some of the data that exists. Thank you. Yes?
Is there any research on mitigating factors that align with these risk factors?
Yeah, so the question was, is there research on mitigating factors that align with the sort of the ecological transactional model that's been presented today? And yes, there are a variety of studies, really, kind of coming back to the discussion of the more risk, the more factors that the children have in terms of across these different levels of ecology, the greater the risk. So that literature does exist. Okay, I'll turn it over to Dan Whitaker now. Thank you.
Thanks, Shannon, and thanks to the FCAP folks for inviting us here. We're really excited to be here. Everything Shannon said about Seattle, I second, and I took a picture of the view from Shannon Dorsey's office on my BlackBerry and emailed it to my wife and said, if we can get jobs in Seattle, this can be your new office. So, Shannon, I hope you don't mind sharing your office with my wife. Okay, good. We're there. My colleague Shannon Self-Brown has given you an overview of kind of what neglect looks like from a prevalence and a risk factor and a consequence perspective. I'm going to be talking about neglect interventions, and I've got this divided, this is part two, I've got this divided into just giving a broad overview of the state of neglect interventions. I'm going to talk a little bit about popular interventions for neglect, or some of the ones that are out there or listed as neglect interventions, and there ain't many. And then some issues for consideration in thinking about neglect interventions. And finally, I'm going to talk some about partner violence. This is so this section will be a little bit disjointed, but that's kind of par for the course for me. All right, so let me start with some very basic premises about interventions for neglect, and I'd probably say this about any problem you could come up with. Nothing will work for all families, meaning the same thing is not going to work for all families, but something might work for most families. Some things will probably be very different, or could be very different in terms of duration, intensity, and chronicity. That is how long we have to serve families. And I want you to keep that in mind when you hear about different interventions. The few that I'm going to highlight, including SafeCare, which Shannon and I, we're the SafeCare people. But the few I'm going to highlight differ in those respects, and we really need to move from the thinking of, well, that's not going to work, to thinking about, who might that work for and who might that not work for, because we may have to think about an array of interventions that vary in characteristics and can be used with different kinds of families. So this is a list. I don't know how many people are familiar with the California Evidence-Based Clearinghouse. If you're not familiar with it, I would suggest maybe you take a look at it. I think if you Google CEBC, it's like the third or fourth link down. Oh, okay, there's cards outside on the table. Perfect. Well, CEBC has a panel that rates interventions on all sorts of different things that are relevant to child welfare. And they've got some different categories. They rate them on a 1 to 5 scale, with 1 being the best rating, meaning strong support, 2 is good support, 3 is promising, 4 I think is, there's not a whole lot of support, and I'm not sure what 5 is, but there is a 5. I've never seen them give anyone a 5. But I think the 2 categories they rate, or they have listed, that are applicable to neglect, one is parent training, and the other is neglect. Under parent training, I've listed out the things they have on their site that are rated as a 3 or better. And 3 generally means there's some evidence that for some level of effectiveness. The ones under parent training that I have a 1 by, which are PCIT, Incredible Years, and Triple P, and I think all those programs have some presence here in Washington State. Those are listed as 1s, and they have the strongest scientific evidence, meaning that these are randomized trials that are comparing this particular intervention to maybe a control group or service as usual intervention. So those are kind of the parent training interventions. The neglect interventions that are listed are home builders, something called the Child Haven Therapeutic something or other. I can't remember the end of it. It's actually. It's here in Seattle. I know it is here in Seattle, which is why I'm blushing right now.
I want you to blush a little more.
Oh, okay. Would anyone else like to embarrass me? SafeCare and Family Connections. I want to do just a few words about parent training interventions. I mean, if you go back to this list, the ones that are sort of the highest rated, the PCIT, Incredible Years, Triple P, and there's some others that aren't on here. The Oregon Parent Management Training model. Most of them use cognitive behavioral strategies. Most of them teach positive behavior management and non-coercive discipline. And most of them teach engagement, nurturing, and the promotion of attachment. So basically their goal is to promote positive interactions between parents and their children, and to prevent the kind of coercive interactions that are going to lead to discipline, heavy-handed discipline that can often lead to physical abuse. What I would say about those strategies is those are outstanding strategies that are very effective for physical abuse and probably for psychological neglect. But they don't really address a lot of the issues or a lot of the factors that come up in environmental neglect, physical neglect, medical neglect, and educational neglect. As Shannon was saying, those things are kind of more social ecological and are kind of less dependent on sort of the specific parenting piece around managing a child's behavior. So the point there is the very best interventions in terms of scientific strength are probably not the very best interventions for neglect. So I just want to talk a little bit about 3 of the interventions that they list. And is anyone here a home builders person? Anybody? All right, so I can say whatever I want. No, I'm kidding. If you look in the literature to try to find information about really any of these interventions, and many of you have probably done this, it's kind of hard to tell from journal articles exactly what these things are. And like I said, we're the SafeCare people, and I'm sure SafeCare is no different. So I was going to invite any of the home builders people to, come up and yell at me after the presentation if I say anything wrong. But these are 3 that I want to highlight. They are listed, again, on the CEBC website as having some evidence for effectiveness with regard to neglect. The Family Connections program, this is a program that was developed by Diane DePanflis and Howard Dubowitz. It takes very much an ecological model. It's done in the home, and it uses a family-centered approach. It operates in Baltimore, and there was an original Family Connections project done in Baltimore, and based on the results from that, there is now a large 8-site replication that's going on at 8 places around the country that I don't know the name of. In Family Connections, there are 4 core components, and these are emergency assistance, home-based intervention, service coordination, and multi-family recreational activities. This is kind of getting families together to do things. So these kinds of things are probably very familiar to you, those of you who do kind of the case management for neglect cases. They also have 9 service principles that they ascribe to in Family Connections, and these are things like community outreach, individualized family assessments, tailoring the intervention, developing a helping alliance, using an empowerment and a strengths-based approach, being culturally competent, being developmentally appropriate, and having outcome-driven service plans. So this is the point where, when I said it's kind of hard to tell what these things are, this is what I could tell what Family Connections is. And that's not to say it's not more than that, but I think you have to dig much deeper than you usually do in journal articles to sort of say, okay, what is this thing? In terms of the Family Connections data, the main data published on Family Connections was a randomized control trial comparing families who got Family Connections for 3 months to Family Connections for 9 months. So really they're looking at the program and varying the length of the program. This was a very messy study, and as somebody who has several very messy studies going on, I'm not trying to be critical. Messy. There was also no comparison group, meaning there was not a services as usual group or a no treatment group. Basically, what they're finding is that there are improvements from pre to 6 month post intervention on a variety of things: depression, parenting attitudes, parenting competence, stress, social support. They're really finding no difference or minimal differences between the 3 and the 9 month intervention. The problem with this, of course, is we don't know whether these families would have improved on their own, since there was no treatment no treatment group, and we don't know if it's better than any other comparison group or service as usual group. Like I said, there's an 8-site replication in progress now. So again, this is a promising intervention as listed on CEBC website. Home Builders was founded here in Washington State. The goal is to prevent the removal and promote reunification. It's based on a brief intervention period of 6 weeks. It's very intensive. My understanding is that caseworkers have very low caseloads. They're supposed to be available basically around the clock for their families, and they're supposed to work with families for 10 to 12 hours per week. So the way this was described to me once is when you're at the point where you're saying we need to get the kid out of the house, that's when you should try Home Builders. And again, if there are people who know more about Home Builders than me, please correct me afterwards. I don't want to, spread false information. So the three main focal points of treatment for home builders are relationship building, motivation, and setting treatment goals. This is really a parent engagement piece. There's a skill building piece around a variety of parenting skills, and there's a concrete assistance piece. So this is really trying to address some of the social ecological things. I think we don't have a refrigerator that can keep food cold, so it's hard to feed our children that kind of food. It's really all I'm going to say about home builders. There's actually fairly good data on home builders. There was a study by Fraser and colleagues in 1996 where they compared home builders to sort of a services as usual, that is whatever similar families would get that was a non-home builders. And what they found is that there was a greater percentage of reunifications for home builders, and those were faster reunifications at 3 months. So this was not a removal situation, these were reunifications. Also, what they found is that at 15 months, 70% of home builders' kids were in the home versus 47% of service as usual kids. So this is huge data in terms of sort of the family preservation approach. And I know sort of economic analyses are big out here in Washington, and this is a very important finding with regard to economic analyses. Very expensive to have a kid out of the home. Another publication followed up on those data, or different data, I should say, because the year is earlier. And basically what they're finding is that home builders compared to service as usual, if you look 6 years down the road, there was no difference in contact between kids who got home builders versus kids who got service as usual. And you might say, okay, well, there's no difference, so they're the same. But that may be true, but home builders is a lot cheaper in terms of preventing kids from being out of the home. So the point is they're staying in their homes and they're not experiencing any more contact with child welfare. So these are actually quite good data on home builders. I think the thing keeping home builders from having the highest possible rating is a lack of randomized trials on it. Okay, last I'll just highlight SafeCare, and again, Shannon and I are the SafeCare people, although I think when Lucy and Rima said, we don't want a presentation all on SafeCare, we both kind of said, oh good, we could present on something else and not be the SafeCare people for a day. But I'll tell you a little bit about SafeCare, and naturally I know more about SafeCare than home builders and family connections, so that'll be my bias, hopefully, is a knowledge one. SafeCare was developed by John Lutzker, who was with us in our group. It was originally started as something called Project 12 Ways, and if you want to know the difference between Project 12 Ways and SafeCare, think of SafeCare as Project 3 Ways, meaning 12 Ways had 12 kind of service focal points, and SafeCare has 3. SafeCare was developed out of 12 Ways to make it more disseminable, and that's kind of what we're working on these days, and I'll tell you more about that at the end of the talk. SafeCare has kind of traveled with John and some of his collaborators. It started in California. It was actually the state of California that said, hey, can you do that 12 Ways things, but don't make it last 2 years, let's have it last 3 or 4 months. And the idea was, okay, what John said is I'll take the things that most people use and that seem to be most effective, and we'll call them SafeCare. It moved to Oklahoma. When John also worked at the CDC with Shannon and I, and Oklahoma, our colleagues in Oklahoma at the Oklahoma University Health Sciences Center worked with the state of Oklahoma in the early 2000s to make SafeCare one of the backbones of their family preservation services. And John was brought on as a consultant, and we were colleagues, so I worked on that a little bit too. But at that point, Oklahoma there was no SafeCare outside of Oklahoma. Finally, when we were all paroled from the CDC, John started the National SafeCare Training and Research Center and hired me and Shannon to help run it. And so now SafeCare is centered in Georgia, and it's about in 9 states around the country right now. SafeCare takes a very behavioral and skill-based approach to treatment. And I'll tell you a little bit about what that means. It's really for parents of children ages 0 to 5. The protocols were developed and validated on parents with younger kids, and we get calls all the time saying, can I do SafeCare with my teenagers or with my families with teenagers? And we say, you could try, but you wouldn't want to. And we say go call Triple P or go call some other program that's got a teen focus. There's 3 modules in SafeCare. Those focus on health. It says SafeCare. It should say safety. That's what happens when you edit slides in between songs on American Idol. Health, safety, and parent-child interactions. The focus of the health module is really to help parents make good healthcare, and make good healthcare decisions about their children when they're sick or injured. And I don't mean, which health plan should I choose. What I mean is identifying when their kids are sick or injured and doing the right thing about it. Calling the doctor, knowing how to treat the kid at home, or taking the kid to the emergency room. The safety module is really focused on environmental neglect, and I'm sure many of you have been in houses of neglectful families and know that there are often environmental hazards. Whether it's, my favorite story one of our trainers likes to tell is that the family who had their TV balanced on a surfboard that was held up by 2 milk crates. And this was a big tube TV, not a nice flat screen. And the family was hell-bent on not moving the TV because they liked it so much like that on the surfboard. But many of you have been in these homes and you know that there are multiple safety hazards, and these are often the reasons that kids come into care. A kid got hurt when something fell on him, or they for a variety of reasons. So safety is really focused on addressing those environmental hazards. And then finally, there's parent-child interactions, and this is more the typical parent training focus, where we're really teaching parents to engage their children, talk to them in a positive way, set up structures so that they're not having to use coercive discipline and so forth. SafeCare is 18 to 20 sessions. It's about 90 minutes per session. We do about 5 to 6 sessions per module. We use a structured teaching model for helping providers train parents, and I'll show you that in a minute. We also teach a structured problem solving that really is used to, I know you've probably all heard from Shannon the term COW, the crisis of the week, and we're under no illusion that health, safety, and parent-child interactions are the only problems that these families have. So we teach a structured problem solving that can help a provider work with a family to say, well, gee, the power is going to be turned off in 3 weeks if I don't pay my bill. What can we do to address that? Or I needed a ride to the doctor's next week. I don't have a ride. How can we think through that and help you problem solve? And the goal really is to teach the parent to do that, not to do it for them. So in terms of the teaching model, we use this assess, train, assess sequence for each module. So really what we're trying to do is see where the parent is before we train them on skills, and then reassess where they are. And that allows the provider, the caseworker, to really see, okay, have we made improvements or not? For the training part, we use a sequence of explain, model, practice, and feedback. And this is a way you can teach anyone to do anything. Basically, what it involves is explaining the behavior that you're going to teach them. Okay, what I want you to do now is look at your baby and smile at her and talk to her. And babies really like that because it tells them you're engaged and it gives them some control if you imitate them and so forth. So you explain what you're going to teach them to do. Then you model it for them. Okay, Mom, watch me. I'm going to do it. And hopefully the baby doesn't cry when you pick her up. And then you have them on practice. It's, okay, Mom, now it's your turn. You try it. Let's see you do it. And while the mom is practicing, very important, again, this is the behavioral nature of SafeCare. The providers are actually taking data on how the mom is doing. So we have structured checklists that the providers use, and then they give feedback to the mom. Well, gee, Mom, you did great. You did X, Y. I like how you're smiling. You talked a lot. Next time try holding the baby this way. Baby sometimes like that, and so forth. So we're trying to train parents to a specific set of mastery criteria that comprise each module. In terms of the data on SafeCare really developed out of a different school of thought than I think either home builders or Family Connections. But there are lots of what are known as single case studies on the modules of SafeCare, and these are really developmental studies. There was a nice comparison group study in California. What that showed was that families who received SafeCare were 75% likely to have a report of child maltreatment than families who received services as usual. Now, this trial also had some methodological issues in that it wasn't what is known as an intent to treat trial. It looked at It looked at families who completed all of SafeCare as opposed to started all of SafeCare. And so what happens? All the really tough families drop out. And so this is one of the reasons SafeCare doesn't have a higher rating on the CEBC website. The Oklahoma trials were started in the early 2000s. There are 2 randomized trials going on in Oklahoma. One is actually a statewide trial in which providers in half of the state were randomly assigned to do SafeCare. These are child welfare workers who do family preservation services. And the other half just kind of continued to do what they were doing. So in that way, the state was doing a large implementation of SafeCare, but doing it in a rigorous way where they would be able to know, is SafeCare helping? The second trial was a prevention trial that was done in Oklahoma City. The data the prevention trial was focused really on families who came into mental health services. And what's kind of interesting about this trial is that they compared bachelor's level providers who are doing SafeCare to master's level mental health providers. And so it's a conservative test of whether SafeCare is effective in terms of the SafeCare providers not having, as great an educational background as the mental health providers. The prevention trial, and these are not our studies. These are the prevention trial is Jane Solofsky's study, and the statewide trial is Mark Chapin and Deb Hecht are the main investigators. But the prevention trial is finding pretty good results. They're seeing SafeCare relative to usual mental health services. They're getting a variety of differences in favor of SafeCare, including reduced parental depression, increased parental social support, lower CAPI scores for the SafeCare group relative to the mental health group. They're also getting findings on family engagement. Families are much more likely to they're much more likely to engage in SafeCare. They're much more likely to complete SafeCare. The statewide trial, we don't have outcomes yet, family level outcomes. We do have some provider level outcomes that are kind of interesting. And basically there was, what we're finding, or what they are finding, is that the providers who are doing SafeCare are happier than the providers who are doing services as usual. And the happiness is measured in 2 ways. One is by attrition. One of the findings is that SafeCare providers were, the retention rates of SafeCare providers 3 years after they were trained was about 57% compared to service as usual providers, which was in the 20s. And so again, from an economic standpoint, that's a good thing that, we all know it's expensive when folks quit. We don't have family level outcomes, but we're looking forward to those. I want to be aware of time here, let me just take a few more minutes and then we'll take a break. So just to compare these things, so home builders, family connections, and SafeCare differ really in many ways. I've hopefully given you enough of a description so that you can see they differ in intensity, they probably differ in when it's appropriate, they differ in their structure, they differ in whether they're tailored. Basically in SafeCare, everyone gets the same thing. There's three intervention pieces, and everyone gets them. And their mastery, we have mastery criteria, so if your house is not a mess, then safety goes pretty quickly, as opposed to family connections, which is tailored for everyone based on sort of what they need. And home builders, I think, is sort of in the middle. They differ in what I would call kitchen sinkness, which is, again, to the extent that they try to provide everything to everyone. And they differ in what I would call social workiness, which is kind of a social work approach versus a kind of a supportive case management approach versus kind of a structured behavioral approach. And again, I'm not saying any of these things are better than one another, but I think we need to start thinking about what is best for whom. And unfortunately, there's not a lot of data on that. So what I would suggest is these three kinds of interventions may actually be different for different populations. I just want to say a few more things about intervention considerations, things to think about. One is, this is the same slide you couldn't see when Shannon put it up, the social ecological model slide. But what I want to say about social ecological models is I think we all believe in them. We all know that there are risk factors at various levels. But when we think about intervention, they're useful only to a point, in that you kind of got to pick where you're going to intervene. Even if you try to take a very holistic and strengths-based approach where you're trying to tailor things for every family, you still can only do so much. So social ecological models, useful to a point. The broad intervention principles, these are also useful, but only to a point. These are some principles from Jim Gaudin's. He did some large summaries in the 90s for some federal agencies about recommendations for addressing neglect, and he had some broad principles, and these are really very consistent with what Family Connections does. And I dare anyone to raise their hand and say, I don't agree with one of those. I think we would all agree with all of these. But the problem is the rubber still has to meet the road, and we still have to decide what to do. Just a couple of words on poverty. Poverty is highly related to neglect. The neglect rates among low income, I think this is from NIST, is 46 per 1,000. That means the non-neglect rate is 954 per 1,000. So most people who live in poverty, at least according to these data, are not neglectful. So poverty is not the whole story, but it is a big part of the story. There's some research by a couple of researchers, Paxson and Waldvogel, who have done economic analysis, or not economic analyses, but they've looked at the impacts of like child welfare reform on neglect rates. And one interesting finding from a 1999 publication was that they looked at child welfare reform from the mid-'70s through, I think, the early '90s. And what they found was that child welfare reform, or greater child welfare, when there was more attention to child welfare, when there was more resources put into child welfare from an economic standpoint, that is providing resources, then neglect rates tended to go down. But they also found that abuse rates tended to go up. So there's a story in there. I'm not sure what it is. The problem with poverty is, who in this room can really do a whole lot about it? We have to operate in the environment, and we can do things, lobby our legislatures and go out and vote and all that stuff. But in the meantime, we still all have to provide programs. So maybe one of the last things I'll say is more better? Again, I would argue that maybe sometimes, but certainly not always, and there's some data to suggest it's not always. There was a review by Jen Kaminsky, a colleague of ours at the CDC, with some other folks, and she looked at parent training programs that were actually targeted toward youth violence, not necessarily child maltreatment. So there may be some differences there, but what she found is when you take a good, high-quality parent training program and you add sort of a lot of ancillary services onto it, you actually get lower effect sizes than when you just do the parent training program. And you could think of, she doesn't, you don't have an explanation for that, but you could think of ones that, if I want to teach you one thing and teach it to you well, you're probably more likely to learn it than if I try to teach you 10 things and teach it well. And so that's a potential explanation. We don't know why. We all worry about attrition and do parents finish the programs? I've heard Matt Sanders, who is the Triple P guy, make a very, Matt could sell me the Brooklyn Bridge, but he makes a very cogent argument about, maybe this isn't really attrition. Maybe this isn't parents dropping out. Maybe this is parents deciding, you know what, you've been coming here for 3 months and I've gotten just about as much out of this as I'm going to get. And so this is not me dropping out of the program. This is me saying, I've topped out in terms of what I'm getting. And so maybe it's more of a self-selection or a self-directed kind of disengagement with a program as opposed to, I'm a failure to complete. The other piece I'd say about this is if we have programs that are more targeted and shorter in duration and we can match them to the right populations, then perhaps we have greater reach because we can provide services to more families. We have this going on in Georgia right now where we have a large rollout of SafeCare, and the money for SafeCare to pay providers is coming from a large pool that pays for lots of different things. And there's a lot of discussion now about how many SafeCare cases should we see? Does that take money out of foster care cases and so forth? And so someone's got to figure out sort of how do we divide this pot of money up to provide all the services. And So how do we deal with what some people call the frequent flyers of the child welfare system? We tend to use what you could call an acute care model for everyone. That is, when you're sick or when there's a report on you, we'll come out and we'll give you a treatment, and then we'll leave you alone until the next report you have, and then we'll come out and probably give you, the same treatment, and then that cycle continues. And so, we may have to think about different kinds of interventions for different kinds of families who are engaged in the program. The problem with all this is we don't really have good assessments to figure out who's going to be the frequent flyer and who's not. I have some data on that I think some of you had seen before. I'm gonna skip it in the interest of time because we are running a little behind. But I think I'm gonna stop with this section here. All right, I think we're gonna get started back again. So we're on part 2.5, which is addressing partner violence. You saw when Shannon presented sort of the definitions of neglect. One of those definitions is exposure to violent environments. And from what I can tell, this is handled a little bit differently across states, exactly how partner violence is handled, but clearly it would fit within that definition. So I think probably I don't have to convince you that partner violence is a problem, and why we should think about partner violence when we think about child maltreatment. But I will just kind of run through some arguments. One is why should we consider them together? One is we know from the data that there's a large overlap between partner violence and child maltreatment. If you look at families where there's child maltreatment, the prevalence of partner violence has been estimated to be around in the mid-40s. This was a review done in 1998. Number two, we know that there are detrimental effects for children and adults also, of course, on partner violence. There were 2 recent meta-analyses of the effects of partner violence, and those have both shown that independent of child maltreatment, even if you control for the child maltreatment-related variables, partner violence still has a negative impact on a variety of child outcomes. 3, partner violence can attenuate the impact of other programs. What I'm referring to here is probably most of us know about the Nurse-Family Partnership Program and the studies associated with that. The very well-known study in Elmira, New York, that showed over a period of 15 years there was fewer child maltreatment cases in a subsection, portion of that study. There was a subsequent publication that some of you may know about, others may not, that basically showed that it was also where there was partner violence present, NFP didn't really work so well. And last, there are common risk factors for child maltreatment and partner violence. Many of the things Shannon said, if you just took out the word child maltreatment and put in the words partner violence, you still would have had true statements. So the idea is that these things often come from the same place, and if we can change one variable and affect both outcomes, then that's like a buy one get one free. Whoops. Okay. So if we look at what works in partner violence prevention, the short answer is not a lot. There are very few good, solid studies that have shown preventive effects or even intervention effects for populations of people who are likely to perpetrate partner violence. We also look at where has most of the research been conducted. If we think about this on a prevention continuum and I assume people are familiar with this, from primary prevention of looking at people who have maybe not yet perpetrated partner violence, to secondary prevention, where these are people who have maybe done some partner violence, but maybe where there's not injury yet, to a more tertiary prevention, where we have the people who are really what we're trying to do is prevent further injury. What we can see is that the most of the research has been done where the 2 arrows are. That is, there are some studies on primary prevention. These are mostly studies of school-age children, you know, middle schoolers and high schoolers, their curriculum-based school programs on primary prevention. And there are also a fair number of studies of tertiary prevention. That is, these are studies of working with guys who are in batterer intervention programs or women who are in shelters to look at sort of how do those people sort of change over time. Where we have a big, huge gap, I think, is probably right where most of the child welfare population would be, which is kind of in the late primary, early secondary prevention area, where, you know, these are people who I don't want to make light of this, but may have dabbled in partner violence. There is clearly a lot of psychological abuse going on. There may be some pushing and shoving, but it really hasn't escalated to, you know, full-out brawl where there's severe abuse and so forth. There really are very few intervention studies around that. So if we look at what do most home-based programs do about partner violence, and again, here I'm talking about sort of programs that would target a welfare population. Mostly what they do is refer and support. That is, if they suspect there might be partner violence, then, you know, here's a referral to the local shelter or some other service. They may do safety planning, but this is actually fairly rare from what I could tell. Now, this is another area where, you know, this is not the kind of information that makes it into the scientific literature or even kind of a non-scientific literature where there's just descriptive data. So it's very hard to get information on these kinds of things. Ann Duggan, in her work with Healthy Families Hawaii, published a study in 2004 where she was looking at the impact of the Healthy Families model in Hawaii, and she didn't find an impact of the program, but she really pointed to partner violence as one of the big problems, along with substance abuse and mental health issues. And one of the things she realized is, in terms of from some qualitative work she did, is that most of the providers really don't know what to do. They don't know how to recognize partner violence, and if they see it, they don't really know what to do with it. There was another study in 2007 using a nationally representative sample of families and child welfare agencies that showed that most families don't even get formally assessed for partner violence. And when they do, there was a study published by Diana English in 2009 that stated that Washington State uses just one question to assess for partner violence. And this is in no way to pick on Washington State. In fact, that's probably one more than most states use. But the point is that when there are assessments, they are fairly minimal. To my knowledge, there are very few curricula for in-home intervention with a population that's at very high risk for partner violence, but where the violence is not of the type that, you know, the woman's got to get out of there and the guy needs to either go to jail or a batter's program. Okay, look at that. I didn't do that on purpose, I don't think. So how should we think about a partner violence intervention for this kind of population? And I never thought I'd be old enough to be quoting, to be putting up old quotes, but here I am. And I'll quote Kurt Lewin, the famous social psychologist who said, "There's nothing so practical as a good theory." And this is nowhere is this truer in the area of partner violence, where there's a huge amount of controversy. Is anyone in here kind of identifies as a partner violence person or a violence against women person? Not too many people? No? A couple people. So if you do, then you probably know what I'm talking about. There is a huge controversy about what partner violence is, what it means, why it happens. And basically, the people fall into two camps on this, and some people are kind of more in the middle, but we need more people in the middle. There's one camp has been called the feminist camp, and these are people who think that partner violence is about male control of women, male dominance of women, and that, you know, the way to address that is through sort of broad social change that would affect things like equality and so forth. The conflict camp is more of the mindset that partner violence is something that happens because conflict, partners argue about things, they don't have good social problem solving skills, those arguments escalate and turn into fighting. I think what's clear and where there's certainly some common ground is I think that everyone recognizes that IPV, like child neglect, is not one thing, or it is one large thing with many little things underneath it. It's not a unitary construct. There's really different forms of partner violence. There's different motives and things that trigger partner violence. Certainly there are cases that fit the feminist model, and certainly there are cases that fit the conflict model. And I think more and more people are thinking about what are the kinds of interventions we can use for particular populations? I think this is actually an area that partner violence is moving and is a little bit farther along than maybe child neglect. All right, so a little bit more on what does partner violence in child welfare populations look like. I'm drawing on some recent studies by Diana English, Jane Solofsky, Ann Duggan and Amy Wyndham, and Hazen, whose first name is I'm blocking on. Partner violence, if you look at child welfare populations, like I said, partner violence rates are high, around 40% or even higher, depending on how you measure it. Actually, if you measure something like psychological aggression, the rates are in the 90s. I think if you measured psychological aggression among college professors, you'd probably get rates in the 80s. Well, that's not to knock college professors. That's to say that the items are very, somebody always usually endorses one of the items. You know, my partner gets mad at me sometimes and storms out of the room. Well, yeah, I do that. So if you look across those data, what you might see is that most of IPV, and most is probably too strong a word, but if you take means and medians, if you believe in those kinds of analyses, a majority of partner violence is conflict-related and low-level. So these are people that are fighting about problems or arguing about problems. It escalates into psychological abuse, so, you know, why did you come home late? You know, you never care about me, and oh, you're always trying to control. And then these things escalate into a point where, you know, one person is, trying to leave, and the other person blocks them, and someone gets pushed, and gee, you pushed me, now I'm going to slap you, and so forth. So most of the partner violence tends to look like that. A good bit of the partner violence is what has been called bidirectional. So what this means is that if you ask a person, either a male or a female, about, you know, who's doing the hitting, a good bit of the partner violence, regardless of how you measure it, will be reported as, I hit my partner and they hit me. And now that tells you a little bit. It doesn't tell you all that much, because you could get that based on the scenario I just described, where, you know, you pushed me and now I'm going to punch you. Or you could also get that based on, you're coming at me with a baseball bat, yes, I'm going to throw this frying pan at you, or whatever the situation is. So it could be defensive, it could be conflict escalation. When people measure bidirectionality, and I've done some of this work myself, generally we don't have information on motives. I mean, that's a problem in the field, and again, the field is moving more to a deeper understanding of how to measure that. But if you look at the literature, what you see is a large majority of partner violence is bidirectional. Most partner violence includes psychological abuse. This would fit with the conflict notion that, insulting someone and calling them names is likely to lead them is likely to lead a situation to escalate into physical violence. The other thing is that conflictual interactions tend to be generalized. So the people who are likely to be involved in partner violence as perpetrators, they don't generally just get into conflicts with their partners. They get into conflicts with their peers. They fight with their coworkers. They fight with their bosses if they have jobs. They fight with their parents. And they fight with their children. So these are people who don't have a lot of good problem-solving skills and social interaction skills, and there are a variety of conflictual interactions in their lives. So based on that, here are a couple of other relevant points that have been shown pretty broadly in the literature. When you have bidirectional IPV, when you have both partners hitting, that's worse. You get a higher likelihood of injury, and again, that fits with both explanations that I offered. That, you know, here comes my wife with a kitchen knife. I better get something to hit her with, or something like that. And so it's a very serious situation, or it fits with the situation where there's escalation. So we know when there's bidirectional IPV, that's particularly bad. It's worse for kids as well. Like I said, partner violence is related to generalized aggression. We know that in younger kids in longitudinal work, family conflict predicts partner violence. So that is to say that parents who argue a lot with their teens, and not necessarily physical arguments, but more verbal conflict, those teens are the ones who go on to be perpetrators of teen dating violence. And when I say perpetrators is a very loaded word, but when I say perpetrators, those are people who may do pushing and shoving and slapping. Again, most of this is low level. There are certainly many cases, and again, like Shannon said, one case is too many, of what we would consider the battered woman. There are certainly those cases, but it's not the majority of cases. There's also this phenomenon called assortative partnering. And what that means is people who are prone to violence, they tend to find each other, and they tend to hook up, for lack of a better word. And I don't mean that in the teenager sense, or I mean that in they get together and they form relationships and partnerships. And there are a variety of explanations for this. They may have similar interests. They probably live near each other in low socioeconomic status areas. But there is a tendency for people who are prone to violence to find each other and partner together. So if we look at sort of what this means, I mean, one, we've got providers with few tools to assess or intervene. We've got, and I'm sure you've all seen this in your families, we've got conflict between family members, including partners and other non-partners. We've got poor conflict resolution skills. We've got conflict that may escalate, and we've really got few positive interaction skills. And again, if you look at neglectful families, this is generally the case. They're not good at communicating with one another or showing, using positive interaction skills. And so this is another area where, we've got a lot of problems, and we've got, again, we could do social ecological analyses and, find that, everything at every level relates to partner violence. Basically, it's everything bad relates to partner violence and child maltreatment. But we still have to choose an intervention point. And one of the points that we're exploring in some of our work in Oklahoma is relationship skills training. One of the reasons that we're looking at relationship skills training is there actually are very good interactions for relationships. There are very well validated interventions that have been developed for couples who fight a lot, not necessarily physically fight, but they have poor relationship quality. There are good programs they go through, and there are improvements in communication skills and so forth. So one of the things we're doing is we are developing an in-home intervention. We're using some skills like active listening. You probably all know these if you've got the backgrounds that I assume you have. Assertive instead of aggressive communication. So one of the manuals we're looking at calls us how to complain effectively. Taking timeouts, we think of timeouts as parents putting children in timeout for misbehaving, but timeouts can be used in an argument. If things are getting too heated, you say to your partner, you know what, let's talk about this in an hour, I need to calm down, and you go take a walk or whatever you do to calm down. That can be very effective. Teach people how to talk about problems and how to solve problems as a couple. So these are some of the strategies that are very well documented to work with non-violent populations, and I think they will work with violent populations, or I should say populations that are prone to violence of the conflict type, not of what we would say the terroristic type, where we've got this control freak kind of guy who's wanting to control every aspect of his wife's life, and he's a batterer and so forth. That's why I have the point up here that we really need thorough assessments to think about before we go in there and try to do relationship kinds of skills. Is this the right kind of person to do this with? And so one of the things we're doing, we're actually, as part of some SafeCare work in Oklahoma, I'm working with Jane Solofsky to develop a module that would insert these things into a kind of a fourth SafeCare module. I also did some work with Lynette Fader in Portland to do a similar intervention in the context of a nurse-family partnership model, and we don't have any data on those yet, but those will be forthcoming. The point is to give people who work in homes a way to think about and potentially address partner violence. So that's kind of the end of the second part, which was separated by the break. I'll take a few questions now, if there are any, on the partner violence piece, and then we can finish the last part. No?
So, as you know,
Fit or not. A lot of the people here are caseworkers, case managers, providing services. I know there's not really an answer for where to send people, but as a consumer, the case manager is really a consumer to the client, we identify a good program. Are there questions that you can ask about what we call here the treatment, whether it's for the big gentleman or the big wrestler? Are there questions they can ask?
Well,
Give some direction.
yeah, I mean, I would say in terms of questions, there actually are some reasonable tools out there for assessing partner violence. I don't know how many people are familiar with the danger assessment. One of the problems in the partner violence world is I think what you're bringing up. There are DV treatments, and there are generally two things. There are shelters for women and perpetrator intervention programs, mostly for guys, although now we're seeing, I think, with some policy changes, there are more and more women who are ending up in those treatment programs. The data on either of those things are not great. So the batterers intervention programs tend not to have strong data. There's some controversy about whether they work or not. And what's really missing there is a look at what's inside the program. So, to say that batter intervention programs don't work is a little bit saying like, medicine doesn't work. Well, what kind of medicine for what kind of problem? But medicine does work, by the way. I didn't mean that. So that's one of the issues. But I would say, one of the things you could do as a caseworker is try to figure out kind of what the nature of the violence is. And again, I mean, if you're shooting in the dark, this would be tough. But you might want to ask kind of when it starts and what happens, and are people injured? There's a danger assessment scale that was developed by Jackie Campbell. I think if you Google danger assessment, you will certainly see it. And what she's done, this is an actuarial scale, meaning it's shown to be predictive of severe injury and homicide. And so it's a very easy 20-item scale that would allow you to run down a list of items to try to figure out is there a high probability of danger for this presumably the woman. And so that might be something I would suggest. In terms of evaluating a program, that's really difficult to say. And I'm not even sure I'd venture a guess at it. Yes?
Are they looking also at intergenerational violence? Because we have a lot of families that have like adult children that are living in the home, and there's violence between grandparents and parents. And are they looking at that also?
So the question was, are there studies of intergenerational violence with violence between parents and children, and even grandparents and children? I know of a few. I don't really know what they say though. The problem with all this is, bad always correlates with bad. So, people who hit their parents are likely to hit their partners, and parents who hit their kids are likely to hit their partners, and so forth. So there are some longitudinal studies of intergenerational transmission of partner violence. And as I was mentioning, I mean, the best longitudinal predictor of partner violence is like a kid's antisocial behavior. So again, no surprise that kids who get into trouble are likely to hit partners. But there are also some family variables that are related to that, again, like family conflict, parent-child communication styles. And so before I left CDC, we had just funded a study that I was very excited about that was looking at whether we could take a general parenting intervention, something like a triple P or a PCIT, that's generally used just to give parents good parenting skills that would include communication and so forth, and a lack of not using coercive punishment. We're looking at whether that had a long-term impact on dating violence. And so the idea is to intervene very early to prevent a behavior that doesn't even exist yet, because most 7 and 8 year olds aren't dating yet. And so that's a study that's ongoing. But yeah, there is more and more of a move towards looking at sort of the longitudinal predictors of sort of the initiation of dating violence.
Because there's adult children that are moving back with the grandparents.
I see.
And so then that's affecting the kids, and it may be more than partner violence, it may be just family.
Yeah,
it's an unnatural situation.
Right, absolutely. And I think the point was, there are lots of people living. Right. Right. Yeah, I mean, I would definitely agree. I mean, if there's a take-home point from this, it's that, people who engage in partner violence are also doing lots of other conflict and violent-related things. Okay, well, let me move on in the interest of time. And part 3, I want to talk a little bit about dissemination and implementation issues. To start, sort of what is dissemination? I think this is a CDC definition or a piece of it. This is really the targeted distribution of information to specific audiences. What does that mean? I don't know. It's how we give stuff out, how we get our message out in terms of programs like SafeCare or whatever your program is. Implementation refers to more the process of adopting and integrating evidence-based practice into existing service systems. So, for a long time, and let me just say, these slides I stole these slides from someone. I'm not sure who. I've seen Mark Chapin present them, and I've seen someone else present them. So I don't know who made them up, but I didn't make them up. If you like them, if you don't like them, you can say I made them up. For a long time, the dissemination, the thinking about dissemination models was the if we build it model, and this is of course the Field of Dreams reference. If we build it, they will come. And the idea was all we had to do was come up with these great programs, do some randomized trials, and understand that they were effective, and there would be a flocking to our doors of providers who were just dying to implement SafeCare or PCIT or whatever your program was. Turned out that didn't happen. So what really happens is a variety of things. One is we build it and they don't like it. Well, gee, that SafeCare approach isn't really for me. I like what I'm doing. Or we build it and they think they already have it. Well, gee, Mr. SafeCare, you do parent training, you do safety, and you do health training. I already do all that stuff, so why do I need SafeCare? So some providers see themselves as already doing what's involved in an evidence-based program. We build it, and people want to come, but their bosses won't let them. And this is often related to cost. It's related to service system issues. Gee, you want to do SafeCare, or PCIT, but who's going to pay for your training? Who's going to pay for coaching? And why don't you just keep doing what you're doing? We build it and they can't afford a ticket. We get lots of calls for SafeCare training. I'm sure the other purveyors of other evidence-based practices do too, that they would like to be trained, but there are funding issues. We build it and they can't find the stadium. What this means is that if you actually look in the literature, there are lots of programs that have been developed and there's good data on them, but there's really not a group who trains the program. And so this is actually what happened when SafeCare went to Oklahoma. Mark Chaffin and his group contacted John Lutzker, who was, the person who developed SafeCare, and there was not a standardized training program, and they put something together so that Oklahoma could do SafeCare. But at the time, there was really no mechanism for doing SafeCare other than to buy the book and do your best. What often happens is people come, get it, and rebuild it, which means they come to a training, learn something, and then they change it into what they think it should be. What often happens is, we build it and they come and they love it and they want 100 more right now, which means, we'll train a few people and then and then I get a lot of calls that say, we need SafeCare out here. Can you be here by next Tuesday? And the answer is no, we can't be there by next Tuesday. And hopefully the rest of my talk will explain to you why. But the lesson here is we really have to think about how we disseminate our programs. If you are a buyer, which I assume some of you are, you really have to pay attention to dissemination and implementation methods. I would argue as much as you have to pay attention to the data. And let me say a little bit more about that. So program implementation is defined as a set of activities designed to put a program of known dimension into practice, or you could say it more simply, doing what you're trying to do. A couple of things that are noteworthy in that definition. One is known dimension. You have to have defined what you're trying to implement, otherwise you don't know if you're implementing it. Secondly is a set of activities. Implementation is a bunch of things. It's not owning the manual. It's not sending your providers to a training. There are a variety of steps to go through. And there's really a process to attend to, and I'll say more about that as we go along. The most common... The most common implementation model, got one laugh, is the most common implementation model is the train and hope. We've done sort of 2 or 3 hour, I guess, lectures on SafeCare where we sort of go through what it is, say a little bit about the data, and we've had people who've come out of there thinking they were trained in SafeCare. And the train and hope model is, you get the manual, or you come to maybe it's an hour, maybe it's a day, maybe it's a week workshop, and the person who trains you hopes that you go out and do it. And we reject train and hope, as do most active purveyors of an evidence-based practice. If you really want to know about implementation, you can get this book. It's a free PDF on the web written by Dean Fixon and his colleagues, and it's basically everything I'm going to say is out of here, other than sort of our own experiences. So implementation is a process, and I'm going to use SafeCare as kind of the model in which to talk about this, because that's what I know. So if you think of implementation as a process, an agency, a state, a county, whatever the unit is, they go through some steps to get there. They start thinking about this practice. So let me think about SafeCare. Let me read something about it. Let me call this Dan Whitaker guy and let him tell me a little bit about SafeCare. So there's an exploration process. And then at some point the decision is made, yeah, we want to do SafeCare, we have the funds to do it, so let's set up a training contract. There's a program installation phase, and this is where our trainers would come out and teach the providers to actually do the model. Then there's the initial implementation phase. This is where your folks, the providers who are trained, they go out and start doing the model. Finally, there's full operation, which is when your people are really, they know how to do SafeCare, you're churning along, and it becomes part of your standard practice. We then move to something called innovation, where you as an agency, or SafeCare, or whatever your practice is your standard practice, and you start thinking about how can we use this in a variety of ways, how can we use it with different populations, and so forth. Now this is a phase where you have to be careful about sort of, are you staying true to the model? And this is a phase where you have to have some expertise in the model to know that. And finally, there's a sustainability piece where we're all in this business. We all know that turnover rates are high. So the people we train today, a quarter of them will be gone next year, and probably half of them will be gone in 2 years. So there has to be some mechanism for sustainability. I'm going to skip through this, but the point here is that in his monograph, Dean and his colleagues talk about core components of implementation. And these are things that are really, well, I guess I'm not going to skip it. These are things that are really critical to implementation, and they're really like choosing the right people, getting ongoing consultation and coaching, doing the appropriate evaluations, and so forth. So we really have to think of, anyone who says, yeah, I can come train you next Tuesday without any more questions, you're probably not going to get a good implementation. So why should we care about all this? The best quote I ever heard is that children cannot benefit from an intervention they don't experience. If you are choosing a program that, because it's evidence-based, then you're believing in that, by definition, you are believing that program's going to help someone. If you don't take care in how it's implemented, then you've wasted your money. The funniest example I have of this is my wife and I were buying a new dishwasher a couple months ago, and of course I'm cheap, so we realized that the dishwasher was $800 or something like that, and installation was another $150. And I said, I'm not going to pay someone $150 to install the dishwasher. I'll do it myself. And my wife said, we are not going to pay $800 for a dishwasher and have you install it. And so the point is, you should not choose an evidence-based practice and not think about installation. Because if it's not put in right, it's not going to work. Okay. Whoops. Okay. So let me just tell you about what we have tried to do in the SafeCare implementation model, and walk you through a little bit about how we do it. And again, I'm using SafeCare as the example because it's what I know. But I would say, what I hope to get across is these are things you should be thinking about for any implementation, whether it's even if a program has no evidence. You may be adopting a program because you like what it does, you like the service components, If you don't worry about these things, then you might not be doing that, even if it has no evidence for whether it works or not. You've chosen to adopt it for a reason. And if you don't make sure it's implemented right, then again, you're missing you're missing a piece. So what we've tried to do in SafeCare is we've tried to balance rigor and efficiency. And what that means is we want to do as much as we can to make sure providers can do SafeCare, but we don't want to do one more thing because that's going to cost money. We've also focused on the dissemination of expertise. And what I mean by this is that it would be a great world for Shannon and me if all the agencies in the country could afford to come to us and say, well, we need so many more SafeCare providers trained. Can you send your trainers out? And gee, two of those people just quit, so send your people out again. And they would keep paying us for that. But the fact is that that's not a sustainable model. We know that money is always tight, and is particularly tight these days. So what we try to do is disseminate the expertise in SafeCare so that sites can self-sustain. When we talk about our implementation model, I talk about 4 phases. There's readiness, initial training, implementation support, and sustainability. Readiness for training is really making sure all the pieces are in place before we do training so that once we come to do training, we can actually focus on the training and not on the various problems that arise. We actually just had one of our readiness meetings yesterday in Olympia with a group there. It went really well. We've had some readiness meetings that don't go so well, but that's why we have them. And we've learned over time that when we don't have these kinds of meetings, that there are problems in the implementation. So readiness is really are factors in place that are going to allow you to do whatever practice you're doing. Readiness can exist at various levels. There are people issues. Have you chosen the right people to do SafeCare? We've trained people who, in the middle of training said, this is a 5-day workshop, and day 3, I don't know why I'm here. I'm an intake worker. I don't even see families. And our trainers go, yeah, why are you here? And that's a lack of communication on sort of who should be in the training and so forth. There are organizational issues that have to be attended to. To do SafeCare, we require ongoing coaching. And if your organization is not prepared to do that, then we wouldn't train you in SafeCare. It's not just a SafeCare thing. If you want to do the nurse-family partnership model, then you have to have nurses. If you don't have nurses, then you can't do the nurse-family partnership model. And then there are systems issues. These are things like, and I think we're learning that these are the biggies. We've trained agencies that have been trained for over a year and have seen no SafeCare cases because they can't get paid for them by their state. And we didn't know that going in, and they didn't know that going in, but their folks have been trained, and now there's no mechanism for their folks to get paid, reimbursed for. And again, these are systemic issues that have to be talked about and put in place before a training happens. Okay, how we get ready, we do a series of phone calls, we have a readiness checklist, we have a SafeCare application, we do a site visit, which Shannon and I did yesterday, to make sure all the factors are in place. And honestly, we don't know all the factors that need to be in place. They differ from one place to the other. And honestly, I'm never as confused as I am when I'm sitting in one of these meetings with people talking about, are the caseworkers going to do this, or the providers going to do this? Because every state has different words for what they call who. And so it can be a very confusing environment, but there is a process to attend to. The site visit, we try to get the trainees in the room, that is the people who are actually going to be doing SafeCare, the management of those trainees, and the funder. And often that's kind of the state or the county level people. Again, when it comes up in training, well, how are we going to get paid for this service? Our trainers don't know that. Our trainers are there to teach SafeCare, and so this comes up in the readiness in the site visit meetings. It's up to the agency management to say, well, how are we going to get paid for this? And usually they ask us, and we just look at the funder and say, how are they going to get paid for this? So that's a conversation that has to be had. I've got a series of slides on what I would call readiness fails, where really we take culpability for this because we shouldn't be training agencies that aren't ready. So this is the one I read. I'm an intake worker and don't really work directly with families. Why am I here? We've had trainings where we had prepared for training and We get there, and well, Cindy couldn't make it, so she sent me instead. That shouldn't happen. We have I have to do all that. And this is, again, we really want people to know what they're in for. We want agencies to pick people who will buy into the approach that we're taking. Like I said, SafeCare is very behavioral and structured, and some people don't want to do that. We've had people, I might even have this up here, we had at least one person leave who said immediately after training, you know, this isn't how I want to practice social work. And you know what, that's fine, and that's not a knock on her, it's an inconsistency with what our model is. Here's some other readiness fails. These we get all the time. Number one, my families are going to hate this. Number two, my families will never agree to let me look in their cabinets. Number three, my families will never agree to be recorded. Actually, you know, one of the things we do in the readiness meetings is, in fact, families don't hate SafeCare. In fact, if you look at the satisfaction data, they actually like SafeCare more than they do sort of services as usual. You have those data from Oklahoma. Our safety module can seem very invasive because you're going through cabinets looking for safety hazards that kids can get at. All of the caseworkers think that families are not going to go for that. In fact, I can't think of an example where we've had a family reject a consent to do that. And three, my families will never agree to be recorded. We use audio recordings for fidelity monitoring. And the fact is that, and hey, I get this, that no, it's actually you, caseworker, who don't want to be recorded. The family could actually care less, but it's you who don't want to be recorded. And the truth is that once people get used to it and they get used to the feedback they get from their coaches, they actually like it. And we're seeing that in Oklahoma, that SafeCare with coaching, which I'll talk about in a minute, is actually, that's the good SafeCare. The evil SafeCare is SafeCare without coaching, where you have this very complicated manual and you really don't know what to do. Here's another one. Oh, forget all this skills business. When can I get my certificate? We do certify home visitors. It's you know, these are fairly arbitrary criteria about when somebody is good at SafeCare, and people get very focused on this. They want their certificate, and my analogy for this is, you know, okay, 16-year-old kid, you've got your driver's license, but I'm still not riding with you. Here's another one. This is an actual, these are all actual ones actually. March 2008, we absolutely have to be trained by SafeCare in May. We got on our contract people, we got out there, we did the training in May. The number of SafeCare cases seen to date, 0. This is one that just happened. This was in an email from somebody who was trained in July of 2009. There were systemic issues that didn't allow them to start. We emailed the person and said, the director, and said, you know, it's been 8 months since your folks have been trained. How about we give them a one-day refresher? The email back was, you got to be kidding me. The state doesn't do its job, and now we have to go through training again. No thanks. I get it. But these are problems we hope to head off in the readiness piece. All right, I've got 5 minutes. Let me cut to the chase a little bit here in terms of some other things about implementation. One of the things about implementation, you're going to see almost all programs do some kind of workshop, and workshops are great. What we know though is that workshops don't allow you to implement a practice. If you buy a manual, you're probably not going to do the practice. Karen Blase, who is very well known in this regard, calls her a bookcase full of manuals kind of a wall of shame for programs that essentially use manuals to disseminate their programs. What you really need is in-field coaching, and actually this is becoming more and more common to do this. Coaching is supposed to be collaborative and supportive and not punitive. Again, this is the example of the caseworker who, you know, they don't want to be recorded and they say the family's not going to like it when really they think they're not going to like it or they're worried about that. But what the data suggests here is if you look at the last column, this is a meta-analysis of educational practices used by teachers following training. And the only way you get implementation of those educational practices, as indicated in the last column, is by doing live coaching. So you can't just tell people what to do. You can't just tell them about a practice. You can't just show them in a workshop. You can't just even have them practice in a workshop. You have to follow them out into their jobs and teach them what to do. What we usually do in our SafeCare coaching model is we have a SafeCare trainer do an initial training for someone we call a coach and someone we call a home visitor at the agency. Once that initial training happens, the coach at the agency is responsible for ongoing coaching of those providers. What ongoing coaching is making sure those providers know how to do SafeCare. What we do is we try to provide support to the team through the coach. What we want is the coach to become the local expert in SafeCare. This is how one way we're trying to disseminate the expertise by not, we don't want to get calls every time you're not sure how to do this in SafeCare, do that in SafeCare. Go ask your coach. Your coach is supposed to be someone who knows. But the coaches need to learn too, so we work through the coach. Sorry, I'm going a little bit fast here. Sustainability. One of the things I want to say about sustainability is what we've done at our center is we've developed a trainer training model. Now, our trainer training model is meant, like I said, we all know turnover is high, and the trainer training is supposed to allow a site to self-sustain or expand their SafeCare operation. So once you have your own trainers, you don't need us. You just train your new people in SafeCare. Whoever the trainer is, they are responsible for ensuring implementation with fidelity. This is how the model looks. Our trainer training model, we sit at the top. Our eventual goal is to support the SafeCare trainers. SafeCare trainers at the site, again, this is your person that you employ, will do the initial training and support the coaches. And in fact, a lot of times the trainers and the coaches are the same person. I mean, that's probably the ideal setup. I will say we've got a couple of empirical studies looking at whether we can export coaching effectively and how best to train a trainer. Everyone does trainer training, but nobody ever looks at how well those trainers train people. And the studies that do look at it, guess what? They find out they actually don't do all that well. So it's like the game of telephone, but by the time it gets to the end of the chain, you lose a lot in translation. So with 1 minute left, I'm going to sum up what we think are the most important points of our talk. Number one, I think you probably already know this. Neglect is the most prevalent form of maltreatment. It's good news. There are positive trends in funding, research, and interventions for neglect. Number two, there is no panacea for neglect. There is no single intervention that's going to work for all cases of neglect. There's heterogeneity in those cases, and we need to start thinking about, is X better than Y? We need to stop thinking that way. We need to start thinking about, will X work for this kind of family and Y work for that kind of family, and start thinking about a menu of interventions that can be matched to family needs. There are really few programs with a strong evidence base. These are not in a good order. I should have, not all neglect cases are the same as the point I just made. And the last piece is, regardless of the evidence, you really have to pay attention to implementation issues. Even, like I said, even if a program has no evidence, even if there's no study, you should still be attending to, are providers doing what you want them to do? So these are our contacts. If we'd love to hear from folks if there are follow-up questions, and I've left you all of 0 seconds for questions here, but we'll hang around for a little bit, and please email us if you have questions or if you want more information on anything we've said. Thanks a lot, and I'm sorry we didn't leave more time for questions.